Hello, everyone, and welcome to another Whiteboard Wednesday. My name is Kristen King, and I am going to be your host again this week. I am joined by my colleague Patrick Gauthier, and today we will be talking about integration, behavioral health integration for ACOs. So I'm going to bring Patrick on screen with me. And as I get Patrick connected, I want to let you know we're hoping that our colleague Phil Rayner will be joining us. Phil was originally scheduled to speak today, but he is having a technical issue at his office in Albany, New York. So we're going to go ahead and get started, and he may pop in. So Patrick, let's you and I take it away. Folks, you may already know Patrick from previous Whiteboard Wednesdays. He's our Director of Healthcare Solutions here at AHP, and we've been working together for over 10 years. Patrick, what else should we know about you for today's conversation?
Well, on the topic of integration, I've been in the field now 30 years, and in these years, I've worked both on the provider side and on the payer side. And that really, to me, is the essence of what we're speaking to when we're speaking to ACOs. That is an organization that's a hybrid between a provider organization and a payer organization. So I like to bring that to the table. I think it's very important to understand the culture, both of the provider and the payer. And culture is a theme that's going to run through this discussion around integration, to be sure.
Absolutely. Thanks, Patrick. And so I want to ask you about the integrated delivery system you were working with in Los Angeles a couple years ago. I know you spent a year working with them, and you were integrating behavioral healthcare and social services for people experiencing homelessness. And this is a population with extremely complex medical needs, lots of co-occurring conditions. So that was a really tall order. How did you approach that?
Well, it's a great question. The approach that we took was really to ask some really critical questions related to the selection of the right model for the population, as you noted, a very complex chronically homeless population in Los Angeles, but also a model that would suit the place. And specifically, we were in Skid Row, which is a very densely concentrated area of homelessness in downtown Los Angeles. And we wanted to make sure that whatever we were doing, like I said, was suitable for the population and was going to coexist, if you will, with the place, a very specific place. Three questions helped us approach that particular challenge, Kristen. The first was to identify what are the selection criteria that make the most sense for our clinical workforce and the people they're serving. And in this case, chronic homeless folks with multiple chronic conditions. So that was our target population, if you will. And of course, one of those chronic conditions was mental illness. Second question we had to answer was, how do we paint the most accurate picture of the clinical and the social needs of this complex population? And then the third question we had to answer was, how do we then implement in this very specific community setting with its unique geography, clinical, and social service assets, and its very specific culture?
Okay, so Patrick, what I'd like to do is actually use those three questions you just mentioned to frame our conversation today. You have this great example, this program. I'm going to ask you at the end, so prepare for this, what happened with them. But let's break this down for the folks who are watching. How can they apply those questions to their work? So the first question that you mentioned was, what are these selection criteria that make the most sense for both the clinical workforce and then also the people they serve? So in other words, what is the model of integration that brings together the medical, behavioral, and social services? And how do you pick partners? Like, how do you develop your workforce to be able to provide the services? What's the workflow and the approach that ties your in-house team together with the other partners to make it work for the population? So can you walk us through the criteria that help us determine how to do that?
Sure. In my mind, the most important, the sort of premier criteria is to illuminate what are the behavioral health and social needs of the population you're serving. And of course, that's from our behavioral health standpoint. The medical partners, in this case the ACO, they're going to be asking a very similar question, which is what are the medical needs of the population we're serving? So we need to take all of that into consideration. And there are two paths that you can use to, like I said, illuminate those needs. The first is to look at epidemiological and demographic data. The second is to look at implementing some form of behavioral health screening and social determinant of health screening everywhere you can, so you can gather fresh data. That epidemiological data will come from, for example, the state. States often produce epidemiological data and reports. Medicaid also produces a lot of data. Of course, ACOs very often are going to be in a position where they're going to have claims data, and that claims data will be very indicative of diagnosis and the treatment patterns people tend to be using. So looking to the bigger, broader system, usually the state, in our case in California, that included looking to the county to collect a lot of that data. As far as gathering data in real time, implementing, like I said, a behavioral health screening tool like the PHQ-9. For social determinants of health, a lot of people are turning to the Prepare screening tool. And to be sure, there are workforce implications for both the analysis of existing data, having the analysts on staff to do that work, and then there are workforce considerations for screening, having staff sufficient to do the screening. So I'm going to bring that workforce dimension back to this conversation every chance I get, because I need to understand what my staffing patterns are going to be, what my staffing needs are going to be. The other important selection criteria is to understand what does the community have in the way of behavioral health and social service assets. So I can look to a model from somewhere else in the country, but if I look to, again, this very specific place, and that specific place doesn't have some of the community assets that are required for this particular model, it doesn't do me a whole lot of good. So there's a marriage that needs to take place between the assets that are available in the community and the people that we're trying to serve. Now, among those assets is the behavioral health and social service provider network itself. Is it adequate? Are there adequate numbers of professionals in the community to meet the needs of people? And of course, the ACO is asking itself the very same question from the standpoint of primary care physicians, nurses, nurse practitioners, and so forth. Do we have a sufficient provider network to meet the needs of people? So very important dimension to behavioral healthcare integration. And in the case of a very large homeless population, just to give you an example, of course, everybody wants to find permanent shelter for people, which in downtown Los Angeles, I can tell you, is a very tall order, almost impossible, as we're beginning to appreciate. So that marriage, again, of the needs of the population with the assets that are available in the community has to be part of the selection process. Otherwise, you're going to wind up very frustrated down the road. And thirdly, a third criteria would be to establish, a very clear sense of what are our desired outcomes, what are the desired results for all the work that we're doing, what is it that we're trying to accomplish. So again, to borrow from that example, in Los Angeles, if our objective is to house people, we have to be clear about what that objective is.
Well, and I think that third point you just made, Patrick, is a really important one, because the objectives that you're trying to accomplish, the goals and the outcomes that you're trying to achieve, are going to really drive the decisions that you're making about, what are the right partnership? Are there gaps in the network of providers right now for what we're trying to accomplish? Or if there are gaps, they aren't ones that necessarily affect the outcomes that we're focused on. So that framing around what are we trying to accomplish, kind of surveying what's available to help us do that, can allow us to fill those gaps, or identify at least where the gaps are, so we can create that plan.
Right.
Yeah. So, oh, sorry, go ahead.
No, absolutely. I'm agreeing with you.
So, I want to talk a little bit more about the data piece, but before we go on, for those who aren't as familiar with the idea of social determinants of health and how they affect outcomes and how they affect the service offerings that we might want to provide, can you give the laser focused elevator pitch of what social determinants of health refers to?
Oh, sure. Yeah. Social determinants of health refer to those at an individual and population level, those assets or constraints that people might be experiencing as they relate to their health and well-being. So, for example, household income, we know now, will either make access to affordable health care a reality, or it will constrain access to affordable health care. For people living in poverty, gaining access to affordable health care is very, very difficult. Buying prescription medications is very, very difficult. Housing and stable housing, for example, is also a social determinant of health. Access to transportation is a determinant of health. If I can't get to my primary care physician because I don't have access either to public transportation or I don't have a car, then my primary care and preventive needs are going to go unmet. So there are a whole host of social determinants of health. Those are a few examples: housing, access to transportation, and household income.
Great, thank you. And so for those of you who are watching, if that's a newer concept for you, or if you have questions about the social determinants that are in play in the area and the population that you're serving, go ahead and type those in the comments. We'll have time for Q&A at the end, and also maybe a little bit as we go, so please don't be shy. So Patrick, let's move forward. I want to know more about the data that you mentioned. We talked about how we use data to select the model, but we need to paint an accurate picture of the clinical and social needs of the populations that we're serving. And so, for the LA folks, like we've been talking about, they were serving individuals who are experiencing chronic homelessness. They had a lot of co-occurring conditions that included both medical or primary care conditions and also behavioral health conditions, serious mental illness, substance use disorders. So where do we actually get the data to know what our specific population needs?
Right. No, it's this is a question that vexes a lot of health systems around the country. Part of the answer is that it varies from one state to another, one municipality or one community to another. It's not uniform. I wish it were. CMS does gather, by virtue of Medicare and Medicaid, a uniform data set and a variety of them. So I always encourage people to dial into, to plug into CMS and the data that's available via CMS. It's quite a deep dive, I should say, because they collect a lot of data. At the state level of data, The Medicaid agency, in our case and the example in Los Angeles, we were dealing with a Medicaid population, in part Medicaid expansion population. So Medicaid managed care plans might have data that they can share. Local foundations, community health foundations, oftentimes will have somebody do the research, do the analysis, and produce reports. Again, it varies from one state to another. We were lucky here in California that there are a good number of excellent foundations that invest in painting that very accurate picture of the health and wellness of people here. Provider associations, reach out to your provider association, whether you're a primary care physician or a behavioral health provider, and see what they have at their disposal. But certainly federal agencies like CMS, as I mentioned, and HUD. HUD operates a HMIS system that gathers an awful lot of information. So that, in terms of sources of information, those are the sources I would recommend. The other is, I talked about gathering information in real time. You can begin to gather real-time information. I think there are two ways to do that. One is by conducting your own outreach, community outreach, surveying the needs of people that you expect to serve. So, for example, in our Skid Row geography and with the homeless population, we used the survey and outreach methodology in shelters, in the soup kitchens or missions, if you will, engaging folks there, and also in what are called drop-in centers where people would congregate during the day, and we could conduct the outreach and survey their needs and preferences as well. In community clinics, we were able to implement some behavioral health and social service needs screening. The emergency department is another place where you can do some of that behavioral health, social determinant of health screening, implementing those tools that I mentioned earlier, the PHQ-9 and the Prepare. So you can look at old data, historic data. You can look at more current data by way of outreach, survey, and screening.
So, Patrick, I love this idea of, actually, if the data is not there, go get it. For the group that you worked with, who was literally doing the screening? Was it clinicians? Did they have outreach workers who were specifically dedicated to this?
Right. This was in the midst of the Medicaid expansion. And at that point in time, there was a real emphasis on community health workers being sort of deployed into the community. And you might be familiar with the term health insurance navigator. And so these navigators were enrollment specialists, for lack of a better term. So part and parcel with the enrollment process is engagement and understanding what people's needs are. So you can look to, again, this goes back to the idea of understanding what assets do we have. And if among our assets we have navigators, health system, health insurance navigators, we've got community health workers, we have outreach specialists, we have peer support specialists in the community. Then having done that inventory, it becomes a whole heck of a lot easier to answer the question, how are we going to do the screening? How are we going to do the surveying? Knowing what my assets are, it's a heck of a lot easier.
Yeah. Well, and so, this idea that many hands make light work, by really identifying what those resources are in the community, you can leverage all of them as a way to collectively gather the data that the entire system needs. And that can be part of the integration strategy, right?
Absolutely. Absolutely. For example, and again, I'm here in Los Angeles, so I'm going to use the example of midwives in Los Angeles are used by the healthcare system, by epidemiologists to gather data, of course, related to labor and delivery and pregnancy and wellness throughout pregnancy. And they're a very important asset that in another city, another municipality, another county, it might be very different. Midwives might not play the same role that they do here. So that understanding of the culture and the community is imperative.
That's a great example. And it also really shows that every community really is different. There's not a cookie cutter approach. So you work with what you've got, and it may be incomplete or it may be imperfect, but you can stitch it together and use it as a foundation to build on over time. Yeah. So
absolutely.
We've still,
a lot of if I can just underscore your point,
yeah.
A lot of the data that I've been citing is historic data. And, there are lots of people who look at this data who'll say, well, it's historic. It's this is old data. It's not real-time data, as though it doesn't have any value. There's tremendous value in understanding the patterns and trends where utilization of different services are concerned over time, the incidence and prevalence of disease, to see that over time is incredibly important. So don't undervalue historic data. Now, if it's 10-year-old data, it's very different than if it's a 1 or 2 or 3-year-old data. So try to keep your your analysis of data to the most contemporary data available, but don't, like I said, don't dismiss it because it's not in real time. Real-time data is something we're all striving for, but very few people are there yet.
Well, and that's a really important point. The fact that we don't have the data right now doesn't mean we can't do anything. We can look at that retrospective data and identify patterns and use those patterns to inform not only our decision making, but also the new data that we want to collect. So it's a different value than real-time data, but it is equally valuable. And it's really important to remember that. So Patrick, if we surveyed, we know what the needs of the population are. We know what our workforce can do, what's available in our communities. So we've got this model identified. And then we have some data, whether it's current or retrospective, that tells us that it's the right approach. So how do we then move from the planning phase to the implementation phase that takes into account all of those unique factors that you were mentioning with the geography and the assets that are available in the community and the culture of the community? How do we put this into action?
All right. Well, this is the part I look forward to the most. And that is from an ACO standpoint, from that medical system of care, including the local behavioral health and social service providers from the very beginning. We've been talking about them as local assets and having a unique culture, but we need to take that fully into account from the very beginning. Whether we're building our own solution or we're partnering to develop a solution in the community, we have to recognize that our best efforts to implement something can be really severely undermined by a failure to account for the different cultures. The culture of social service providers, the culture of a behavioral health provider, and the culture of a medical setting and a medical provider are very, very different. And I think a big part of our job in implementation planning is to account for those cultural differences and begin the hard work and long work in some cases of harmonizing those cultures, and as much as we can before we invite the patient into that cultural milieu. Otherwise, we're inviting the patient into something that might be really choppy, if you will. It's not real congruent experience for them. We have to recognize behavioral health and social service providers, like a medical provider, may have been around for decades, formulating their culture, and in many cases, they've been working in the trenches, marginalized and fragmented from the bigger, broader medical system of care. So we need to invite them in and understand that they really know the behavioral and social needs of our population very intimately. In many cases, we also need to recognize that, particularly in the behavioral health sector, and substance use disorders is a very good example, that there are people with lived experience. So their lived experience with addiction, with mental health disorders, imbues and really informs their culture. So we need to understand that and appreciate it. They also know what's possible from the standpoint of growing the workforce, training the workforce, recruiting new people to that workforce. They've been recruiting, training, and retaining people for a long time. So that's a tremendous value that we can leverage. They also know the policies, the politics, the regulations that govern behavioral health and social services, and they know what's feasible. So we can save ourselves a lot of time by inviting them to the table and learning from those behavioral health and social service providers. And of course, they know the culture of the population that you're aiming to serve. There are a lot of folks who think it's enough to hire some social workers and a psychologist and a psychiatrist and drop them into a medical setting and hope for the best. I'm much more serious about accounting for the culture of the provider and the culture of the population that you aim to serve. I've been doing this long enough to know that that it will predetermine the outcome of your best laid plans and processes and other infrastructure investments that you make. Secondly, I think you need to conduct an assessment, a very honest assessment that's designed to establish how your system of care and that behavioral and social system of care will wind up meshing. That type or that scope of integration includes addressing questions like, are we doing this in one location, in more than one location? Are we co-locating our medical and behavioral health providers? Are we sharing information as we communicate what we're doing with that patient? Are we forming multidisciplinary treatment teams that are going to need to communicate and collaborate? And on that note, you really begin to appreciate the different cultures, the culture of primary care, the culture of mental health care, the culture of substance use disorders care. And then we need to address not only the flow of information, but the flow of money. How is money moving through our system? What is the nature of our financial relationship? And particularly if we formed a partnership. And then, the limitations of each of these systems is going to shape the eventual model unless you make some really serious investments in the system. So, for example, medical providers and behavioral health providers are working on very different IT systems. They have a very different focus on quality assurance. They have a very different focus as far as their clinical workforce. So if there are limitations and constraints inherent there, we need to suss that out in the assessment, and we need to address them, especially with regard to social services. If we're thinking we're going to make referrals, closed loop referrals into social services, we should appreciate that many of those social service providers are not on an electronic medical record, for example. They're going to have a very hard time sharing information with us unless an investment is made. And that investment speaks to the last item I'll say, and that is that implementation planning has to address the training and technical assistance needs of your workforce. So for everything we've talked about so far, there is this workforce dimension, and bringing a collective workforce up to speed, harmonizing them is going to take time, and it's going to take. So we need to understand what our timeline and budget are going to be.
Yeah, well, and going back to something you said earlier, it's really important to acknowledge that there is a difference between co-location and integration. And you can have both of those things simultaneously, but simply co-locating services and simply co-locating professionals is not, it's necessary in some cases, but it's not sufficient for integration. It's really this additional thought process of how do these pieces work together? You know, those warm and cold handoffs are certainly part of it, but just handing off is not actually integration. It can be part of the larger model, but simply doing that does not necessarily mean that you're really integrated. And so what I think I'm hearing from you is this, it's really about the people. It's about these different organizations and these different individuals from different disciplines working together, not just in the same building, but truly, you know, in a partnership where they know how those pieces move back and forth. They know how to support one another and how each of them is supporting those individuals that they're serving. And integration is also local. There are great models and there are great case studies, and they can be really educational and instructive, but they're not necessarily going to be a straight fit for every community. And so it's important to look at what is going to work for your specific community, because what makes any model truly be the right model is that it's the right one for the circumstances in which it's applied. Is that a fair summary?
That's a very fair summary.
Great. So, Patrick, we're coming to the end of our time, but before we wrap up, I want to hear what happened with the program in Los Angeles that you were working with on their integration efforts.
You know, that program in Los Angeles is still operational today and serving people, and continues to participate in bigger, more complex integration efforts that are underway here in Los Angeles. And I think most people in our field are familiar, at least with the scope and scale of the problem here. These efforts are at integration are very successful in that if the end game is permanent supportive housing, permanent housing of one kind or another, in Los Angeles last year, we housed over 20,000 homeless folks.
Wow.
So that's a real success story. Mm-hmm. Unfortunately, for a variety of reasons, the homeless population grew last year by a number greater than the more than 20,000 people that were housed. So we're working against a tide of folks that are increasingly winding up on the streets. Again, there are a variety of reasons, the pandemic being one of them, the economy being another. And so they continue to place hundreds and thousands of people experiencing homelessness in one housing type or another. What we've learned in Los Angeles is that housing developers, homeless shelters, food pantries, hospitals, clinics, the city, the county, law enforcement, policymakers, regulators, community health workers, everybody is part of the solution, and everybody has to be part of the solution. We can't leave any of these important assets out.
Excellent. Thanks, Patrick. So I know that you have a resource to share for those organizations who are ready to look at moving forward with integration. So I'm going to pull that up on the screen. And can you just tell us, very briefly, what folks can expect to see from this document?
Sure. Yeah. What we've done is we put our heads together as a team, and we thought about the work that we've done in the recent years, working with accountable care organizations, or ACOs, that were attempting to integrate behavioral health care in a variety of ways. And we distilled from that experience the 5 tips, based on our lessons learned with our clients, that we thought would be of greatest value to somebody who's just getting started. And we're making that available for you on our website. So please take advantage of it.
Excellent. Thanks, Patrick. So, folks, I've put the link to that 5 tips for integrating behavioral healthcare services into the comments below this video. So, go ahead and grab that when you get a chance. That is a free resource for you. And if you have additional questions, please feel free to type them in the comments. Even after the broadcast ends, we keep an eye on that. So, we'll be happy to answer. I see there is one question. And, Patrick, in the interest of time, I know folks are coming up on the end of their lunch break here. I'm going to say we'll come back to this one and give a written answer, but I do see one question about more information about health insurance navigators. So maybe that's something that we can tackle in the comments. And, perhaps that'll be a topic that we can visit in a future Whiteboard Wednesday.
Wonderful.
So with that, it was great spending lunchtime with you, my friend. Thanks everyone for joining us. And we will see you next time for Whiteboard Wednesday. Have a great rest of your day, folks. Bye now.
Bye.